to screen the patient for evidence of lumbar radiculopathy. This is often done in patients who have low back pain, especially if it's radiating down one leg. The way it's done is the patient lies on their back, usually on the exam table, and then the examiner raises the extended leg on the symptomatic side. Or sometimes you raise the leg when it's bent and then you try to straighten out the leg like this. And what you do when you raise the straightened leg is you're stretching the sciatic nerve and the nerve roots. And so if the patient has a lumbar radiculopathy, their pain will get worse. And when the pain worsens, this is called Lessegue's sign or Lessegue's sign. People pronounce it all different ways, but this is evidence of lumbar radiculopathy by the straight leg raise test. Okay, so an acute lumbosacral radiculopathy refers to a patient who presents with the acute onset of low back pain radiating down one leg. They may have evidence of one of those nerve root syndromes we talked about earlier, and they should have a positive straight leg test. So when these things are present, that usually makes this diagnosis. It's usually a clinical diagnosis based on the history and physical exam. And it's high yield to know for your boards that usually the presence of an acute lumbosacral radiculopathy is not an indication for imaging. The only time you need to do imaging is when there are certain high-risk features present. So one of these high-risk features is if you have a high suspicion for a serious cause of the radiculopathy. So for example, if there's evidence of Cauda-Equina syndrome, which we'll talk about in a minute, or malignancy or infection or fracture, then in these cases you get imaging. But usually these things are not present, so most patients don't need imaging. Some other times when you can do imaging are in patients who don't respond to initial conservative treatment, or in patients who have severe intractable pain or severe weakness due to one of those nerve root syndromes. In these cases, when the symptoms are severe, sometimes neurosurgery or neurosurgical procedures are indicated. But if none of these things are present, especially in a board question, then you should know that you usually don't need to do any imaging. In those cases, when you have patients who have mild or moderate symptoms and none of these red flags like these things listed here, then usually all you need to do is treat the patient with NSAIDs or acetaminophen. You can also advise them to modify their activity by avoiding activities that cause pain. And in many cases, if you do these conservative measures, patients will improve over a few days or weeks. Now, if symptoms persist, then you can do neuroimaging because you can see if there's a cause that could be treated. And there are options for surgery and other advanced treatments based on the specific cause, but generally only in cases with red flags that don't respond to conservative therapy. Okay, so now that we've talked about the clinical features of lumbar radiculopathy, let's go through some of the specific potential causes of a lumbar radiculopathy. And we'll start by talking about a herniated disc, which is the most common cause of a lumbosacral radiculopathy. This occurs when there's degeneration of the annulus fibrosus, which is the fibrous tissue that surrounds the soft core of the intervertebral discs, shown in the slide here. When this annulus fibrosus breaks down, there can be bulging or extrusion of the nucleus pulposus, which is the gelatinous material at the center of the intervertebral disc. And when that material bulges or extrudes, it can cause unilateral nerve root compression, and this will present as an acute lumbosacral radiculopathy like we've just been talking about in the last few slides. The diagnosis of a herniated disc can be made by MRI if necessary, but like we've already discussed, in many cases of lumbar radiculopathy, you don't need to obtain imaging, but if you do, that's the way you can diagnose a herniated disc. And then there are surgical therapies available that are used in select cases, usually only when the herniated disc is causing severe symptoms. And then because herniated disc is the most common cause of lumbar radiculopathy, they may ask you on your board exam some details about how it occurs. So you should know that it often occurs with protrusion of the intervertebral disc posteriorly in the spine. So there are two ligaments that contain the intervertebral disc in the spine. One is called the anterior longitudinal ligament, that's shown here in this drawing, and the other is called the posterior longitudinal ligament. The posterior longitudinal ligament sits within the spinal canal, that's what's shown here in this picture, and it covers the posterior surface of the vertebra and the intervertebral discs shown here. And it's generally a little bit weaker than the anterior ligament, and therefore most herniated discs occur posteriorly, leading to lumbar radiculopathy. So a herniated disc is the most common cause of an acute lumbosacral radiculopathy, but there are other potential causes, and so let's go through those now. And the first one we'll talk about is called spondylolisthesis. And so in order to understand this, we first need to go through some terminology. So if you look at the bottom right side of the screen here, this is what a healthy spine looks like. And this area of the spine is called the facet joints, and one portion of the facet joints is an area called the pars interarticularis. And so when that area fractures, that's what's known as spondylosis, and this creates a weakening of the spine. You can only determine spondylosis through imaging, and usually it occurs due to aging and degeneration. And because spondylosis occurs due to aging and degeneration, the term spondylosis is often used to describe osteoarthritis or degeneration of the spine in general. Now, once you have a spondylosis, you can potentially progress to develop a spondylolisthesis, which is a forward slippage of a vertebral body. This is a picture of what it looks like on the slide here. And when you have slippage of a vertebral body and a spondylolisthesis, that can lead to lumbar radiculopathy. This occurs in patients who first have a spondylosis. It's often in adults who have degeneration of the spine, but you can also sometimes see it in children who have fracture of the spine from overuse or trauma. And then a final potential cause of a lumbar radiculopathy is spinal stenosis, which means narrowing of the spinal canal. This is usually an age-related phenomena that occurs because the intervertebral discs shrink with age, and this narrows the foramen where the spinal cord runs. So if you look at this cartoon on the screen here, this is a healthy spinal cord shown at the top. At the bottom is a spinal cord with spinal stenosis. You can see that the canal has become narrowed, and this can compress nerve roots, leading to lumbar radiculopathy. There are a couple of classic imaging findings associated with spinal stenosis that you should be familiar with for board exams. So first of all, the facet joints often show evidence of arthritis. This can be things like bone spurs or osteophytes. Another classic imaging finding in spinal stenosis is hypertrophy of the ligamentum flavum, which is a ligament that holds bones together in the spine. It often becomes hypertrophied in spinal stenosis. And then lastly, in patients who have spinal stenosis, you can see other findings of breakdown of the spine, things like disc bulging and spondylolisthesis. But all these things come together to narrow the spinal canal, leading to nerve root compression. And usually one of the classic features of spinal stenosis is that standing, which straightens the spine, narrows the lumbar canal and tends to make symptoms worse. So that's a nice segue into neurogenic claudication, also known as pseudoclaudication, which is a classic clinical feature of patients who have spinal stenosis. Neurogenic claudication refers to leg pain with walking in a patient who has spinal stenosis. Patients with this condition often complain of leg pain with walking, and that can make you think of vascular claudication, where blood vessels are narrowed, supplying blood to the leg. But the problem is not the blood flow, the problem is the nerves. That's why it's called neurogenic. So when a patient presents with claudication and leg pain with walking, how can you tell it's neurogenic claudication and not vascular claudication? Well, one way is that neurogenic claudication often persists when the patient rests while they're standing. So in vascular claudication, the symptoms go away when the patient rests. They're only effort related. It's not the case in neurogenic claudication. The symptoms persist with rest. Another classic feature of neurogenic claudication that's not seen in vascular claudication in most cases is that in neurogenic claudication, when the patient stoops or adopts a flexed posture, that improves the leg pain. So in a patient who has lumbar radiculopathy from spinal stenosis and leg pain, if they bend forward like this woman in this picture here, that often makes the leg pain better. Another feature of neurogenic claudication is there's usually no pain with sitting. And so you can make the diagnosis of neurogenic claudication usually by symptoms, sometimes with imaging findings of the spine. Most patients are treated conservatively who have spinal stenosis, but there are surgical treatments available in severe cases. Okay, so now let's move on from talking about lumbar radiculopathy and its causes, and we'll move on to another cause of low back pain, and that's a vertebral compression fracture. This refers to fracture of a vertebral body due to weight bearing over time. It often occurs in elderly patients with osteoporosis, and it's one example of a fragility fracture that can be used to support the diagnosis of osteoporosis. Vertebral compression fractures usually occur in the mid-thoracic region, T7 to T8, or in the thoracolumbar region, which is T12 to L1. And when they occur, they can cause back pain and impaired mobility. You can also identify tenderness to palpation of the spine, and this is a classic finding on physical exam in a patient with a compression fracture. The diagnosis is usually made by X-ray, like we talked about earlier, and most patients are treated conservatively and do not require any special surgical intervention. What you do need to do, however, for a patient who has a compression fracture is make sure you're treating their osteoporosis if they have it. So in a board question with a patient who has one of these fractures and they ask you what to do, the